Good morning, good afternoon, and good night. Thank you so much for joining us today for IACH for Nurses webinar today. We are joined by our senior stem cell transplant and survivorship expert, nurse practitioner, Rachel Hamers. Rachel and I have been working together for, I joined VA in 2021, 2022, but she's been at our Veteran Administration Transplant Program for many years. And she oversees our operations for our long-term stem cell transplant and cellular therapy clinic under the guidance of Professor Bipin Savani. Rachel has been pioneer in providing advanced cellular therapies and monitoring this patient after they have undergone stem cell transplant or CAR T-cell therapy at our stem cell transplant unit in a Nashville VA hospital in Tennessee, USA. And she, with Dr. Savani, monitor these patients remotely via telehealth on a regular basis and work with their local team to manage these patients for both long-term complications of the transplantation as well as management of the disease relapse, unfortunately, in a few cases. So Rachel, thank you so much for, first of all, agreeing to share your experience with our audience members here. We have an audience both from the community oncology centers as well as the academic centers who would benefit greatly from your management approaches for this patient. And so again, I want to thank you for coming and sharing your knowledge with our team and everybody in the audience today.
Thanks for inviting me. This is a big honor. Hello, and thank you for attending my talk. This is a big honor for me to be asked to present. My name is Rachel Hamers. I'm an acute care nurse practitioner at the Nashville VA, also called Tennessee Valley Healthcare System. I work in the long-term transplant program, and this presentation is about providing remote specialty hematology care via telehealth. This is a picture of our lovely facility. As I said, it's called the VA Tennessee Valley Healthcare System, and we're located in Nashville, Tennessee. We are part of the VA, and we are one of only 2 stem cell transplant centers for the VA. There's one in Seattle, Washington, and then our facility here in Nashville, Tennessee. We also happen to be the only VA with a long-term transplant clinic. I started working here in 2007 as part of the acute transplant team, meaning we work patients up for transplant, get them through their day 0, and follow them for 100 days after the transplant. In 2011, Dr. Savani and I co-founded the long-term transplant clinic. Our purpose is to care for patients from day 100 through the rest of their life post-transplant. Our long-term transplant team is small but mighty, as I like to say. Dr. Savani is our attending and our medical director. I am our nurse practitioner, and Melissa Johnson is our advanced medical support assistant. Dr. Savani and I see the patients, and Melissa keeps us organized. She keeps the spreadsheet, she keeps our calendar, she calls all the patients and reminds them about their upcoming appointments and sends all the links for the video appointments, as well as organizing travel and lodging and appointments for our in-person appointments. Our coverage area is quite large. Actually, it's the entire United States. As I mentioned, there's one transplant center in Seattle, Washington, and then our center in Nashville, Tennessee. We can get referrals from anywhere in the United States, including Hawaii, Alaska, and Puerto Rico. In the past, when our clinic first started in 2011, every appointment that we had with our long-term patients occurred face-to-face. As you can imagine, this was difficult. It required our patients to travel here from anywhere in the United States. It was expensive for our facility to pay for the gas, air travel, lodging, even some food reimbursement. It was also a quality of life issue for our patients. During the first year, we see our patients at a minimum once a month. So that means every month these patients were traveling here from all over the country, and it would be about a 4-day ordeal. Um, Travel one day, labs the next, see the provider the following day, and then travel home on the fourth day. In 2020, when COVID hit, we had to get creative, and that's when we started offering video follow up, which I can say has been life changing for our patients. Who do we follow in long term transplant clinic? Every patient that received an allogeneic stem cell transplant at our facility. We also occasionally follow other patients, sometimes a patient from Seattle, since they don't have a long term transplant clinic. If the patient is having severe chronic graft versus host disease, they may refer them to us for follow up. Occasionally, we will also get a referral for a patient who was transplanted outside the VA in a community care hospital. What happens a lot of time is these patients may be lost to follow up, and then they're presenting to their VA hematologist or primary care doctor with transplant complications, at which point the local provider will place a consult to our clinic. I will call the patient and see what's going on and get them scheduled to see us. The first time I meet the patient occurs around day 100 post transplant, usually right before they're returning home, wherever they're from. The first thing that I like to do is have a discussion with the nurse practitioner that treated the patient for their 100 days here. I like to get the background information. What kind of complications has this patient had? Did they have recurrent infections? Have they had any graft versus host disease? Are there any barriers to care that I need to know about once they go home? Maybe this patient lives alone and is going to be managing their medications all on their own. Anything pertinent that would help me take care of the patient. Next, I like to have a face to face introduction to get to know the patient a little bit. I like to be able to put a face with a name. I also like to ease the patient. Often they're uncomfortable going home. They feel a little bit nervous. I want them to be able to put a face with a name for me also. I will always give them all of my contact information at this visit, including my direct phone number, my email. We'll talk about secure messaging. Basically, I give them every way to get a hold of me that they could need. I'll always give an overview of what to expect in the long term transplant clinic. Specifically, how often am I going to see you? What do you need to know to be successful in this clinic? Every patient is followed monthly for the first year. We discuss the symptoms that should be reported immediately. If I spell this out to the patient, I find they're much more likely to let me know. Sometimes patients don't know exactly what they're watching for. I also allow time to answer any patient questions about the long-term clinic, and we choose a date for their first video visit with me at that face-to-face meeting. Most of our patients, as I said, are on video follow-up for a majority of their visits. I would say a good candidate is someone that's not having any major complications that are not well controlled. If someone is doing reasonably well, their labs are stable, they don't have a new flare of graft versus host disease or an active infection, they're a good candidate for this. We see them at least once a month for the first year, but more frequently if they're having any issues. Sometimes people will have a flare of GVHD, let's say, and I may see them once a week for a month just to keep a close eye on them. That's the beauty also of having video follow up. We can schedule weekly follow up without being a great imposition on the patient's life. I will say we try to manage as much as we can by video, but I always tell my patients I have a low threshold to bring you here for in person follow up. If I have any concern about their safety or that they're getting the care that they need at home, I reserve the right to bring them here. At each visit, I tend to follow the same script. I find that this keeps me on task and helps me not forget to ask the important questions, as well as reinforces to the patient what signs and symptoms we're looking for. First, I'll always ask about emergency room visits or urgent care visits in the last month. Have they been hospitalized at all? I reiterate that if any of these things happen, they should call me right away and let me know. We also discuss any signs or symptoms of infection in the past month and what those might be: fever, chills, cough, sore throat, nausea, vomiting, diarrhea. We talk about their energy level. Has there been a significant change in the last month, or is everything pretty stable? We also talk about the signs and symptoms of graft versus host disease: skin rash, skin tightening, dry, gritty eyes, mouth sores, a drop in appetite or a drop in weight, chronic nausea, vomiting, or diarrhea, shortness of breath more than they had in the past. One key part of the visit is the medication review. I find that most of the errors that occur are medication related in this clinic. So I make a point of painstakingly going through each and every medication: the name, dosage, frequency. Then I also have pharmacists as part of our team that can email the patient's new medication sheets to help them stay organized. They can also give copies to their local provider so that everyone's on the same page. We always allow time for patient questions, and we schedule our next video visit at the current appointment. I find that if the patient is involved in picking out the date, they're much more likely to attend. I would say the number one determining factor of success in a video clinic is communication. That's communication with the patient, as we just discussed, as well as communication with local providers. So every time that I see a patient, I will compose an email to their primary care doctor, their nurse coordinator, and their hematologist, and any other specialists that the patient has been seeing, and let them know exactly what happened at this visit. What did we discuss? What problems is the patient having? What medication changes did we make? Are there any consults that I need the local provider to place? I will provide the local providers with my email, my telephone, my fax number. If they're within the VA system, it's really handy because we have a nationwide system called JLV where any provider can log in and look at notes from anywhere in the country. We also have an instant message system with Teams. If the local provider is outside the VA in community care, I will also fax my note to them, and I ask that they fax their notes to me along with labs whenever they see our patients. There can be some barriers to remote follow up, but I find that most are easily remedied. The first is if the patient is missing appointments. When I log on, I usually allow 5 minutes grace in case the patient is trying to get connected. If I don't see them by 5 minutes in, I'll pick up the phone and call them. I'll say, "Hey, sir or ma'am, we are supposed to be in a video visit right now. I just wanted to make sure you knew about it." A lot of the time, the patient will just say they overslept or they forgot and they're logging on pretty quickly. Sometimes they'll say that they're having an internet connection problem and unable to log on, or maybe they've never done a video visit and they're not sure how to do it. If that's the case, I'll walk them through. I'll tell them which email that the link got sent to, how to click on the link, um, typing their name and address in, basically guide them through the steps to log on. And most of the time, that gets us connected. Sometimes I have issues with not getting the requested blood work that I need from the local providers. Every visit, I do email and say how frequently I want the labs and which labs that I need. But sometimes I don't get those tests done. I find that that is usually a communication issue. And if I pick up the phone and call the local provider's office, 90% of the time we can get it worked out and get the blood work that we need. There's also one test called the chimerism that we have to have overnight mailed here. We can only run it at our center because we have the donor's DNA stored here. So that one has special instructions, and I often do need to walk the local provider through how to do that. This is a rare one, but occasionally I'll get a local provider who's uncomfortable or unwilling to facilitate my requests. I typically see that when the patient is from a really rural area and maybe the primary care doctor is the one that's seeing them for all their follow ups. If that's the case, we can usually get a community care consult to get a hematologist on board that can help us facilitate taking care of this patient remotely. Sometimes we also have poor communication with a patient or a local provider. Once again, usually if you have a conversation about this over the phone, you can remedy that. If it's not working out and someone is not sending you their notes, not sending you the labs, or not getting the labs that you need, you can always also try to switch providers. Our patients are on upwards of 20, 30, sometimes 40 pills a day. So medication mismanagement can definitely be an issue. That's why we discuss the medications at every visit. That's why our pharmacist will prepare medication sheets anytime there are changes. Sometimes there's a need for in person follow up. I see every patient in person at their 1 year post transplant visit. That's mainly because it's a big landmark for transplant. It's also because there's a large workup involved, about 20 tubes of blood, a bone marrow biopsy, pulmonary function tests, sometimes an EKG or chest x ray. It's a large workup, and I find that it's easier to have them here, to bring them here and do it all at once so that we can go over all the results together. Some patients also report in person at 6 months post transplant. Typically, that is if there's a concern that I want to address, such as the counts are dropping. We might need a bone marrow biopsy to reassess disease status. The chimerisms haven't been great. They're losing their donor percentage. Basically, if there's anyone that I feel is high risk for complications, I may bring them in person at 6 months. We bring them once a year in person for 5 years post transplant. That's just the annual follow up to make sure that everything is going okay. Sometimes the patient will get to maybe 2 years post transplant and request that they are on video follow up only. If the patient is doing well and in complete remission and not having active transplant issues, we will do that. After 5 years post transplant, typically everyone is on video follow up unless they're having a new transplant related issue. We also will sometimes have to bring in person more often for graft versus host disease. If the patient is having a major flare, their local provider may not be comfortable managing that or following our recommendations, so we may bring the patient in person. We like to have lifelong communication with our patients, which video follow up has been extremely helpful at facilitating this. We do see our patients for the rest of their lives after transplant at a minimum of once a year. I always make sure that the patient has all of my contact information. If I'm only seeing them once a year, we'll go over my contact information at every visit. And I encourage them to call me at any time with any questions and remind them that I can work them in anytime for a video visit. Thank you for listening. Here is all my contact information if you have any questions or want to contact me about anything from this presentation. Thank you.
Thank you so much, Rachel. That was wonderful, actually. And I didn't realize that how COVID just completely changed our workflow in the long-term clinic for good, actually, sounds like. So for all everybody in the audience, I encourage to submit your question, please, in the chat box here, and I'll be going over every question one by one with Rachel. So we don't have any question right at this moment, so I'm going to start with some of the notes I was taking during your presentation, Rachel. And again, the goal of this talk is to help other programs to develop similar setup like you have here in Nashville. So when you and Dr. Savani decided that this is a time to pivot a little bit and offer a remote telehealth care to our transplant survivors, can you walk us through the steps which you guys take in terms of the logistics, the training, and kind of some internal guideline document which you must have to develop before you launched the program, and what sort of barriers you faced when you were trying to set up the remote telehealth long-term transplant clinic.
Sure. Yes, we did some training through the VA actually. It was provided by the VA through TMS where we could log on and do like a video safety protocol kind of training. We had to sign some consents. I don't believe that the patients had to do any kind of training, but when they sign up for the video visits, they have to download an app and there may be some training on there. The biggest barrier probably was quite a few of our patients were resistant to change, although they ended up liking it better, but it was a little bit intimidating for them to have to figure out how to work the video, how to do it from home. So in the beginning, we would do some video visits from their local center where they would go and their provider would log them in so that they could learn how to do the visit.
Okay, okay. And so currently, how big is the team? You put on one slide, so it's you, Dr. Savani, and one
3.
coordinator.
Yes. So
Okay.
3 of us.
And what is like an average volume of the patient's visits you complete in like a 1 week period uh, on any given?
Probably, 15, 20-ish, and
Okay,
we do a one-hour slot for every visit because it usually takes nearly an hour to go through all the meds and issues that they're having.
okay, wonderful. Now, I'm sure many of these transplant survivors will need other specialty care also. For example, somebody with graft versus host disease might need some care from the pulmonologist, or somebody with on tacrolimus with CKD needs to expertise from a nephrologist. And so,
Mhm.
how do you coordinate with other consulting services? Somebody who is actually in a home base and you are just doing remote care.
Yeah, so all of our patients, will have a hematologist at home also. The first year, they're usually seeing them every 2 weeks, and then there will also be a nurse coordinator. So every single time that I see the patient, I send an email including the primary care, the hematologist, and the nurse coordinator, and we will ask for any consults that we need, and they'll place them for us.
I
If
see.
it's a
Okay.
local patient, I can place it myself here.
Okay. Okay. And so what proportion of the patient right now in your practice are like local and rest is like remote, out of state patient, would you say?
Definitely more remote. I mean, I have quite a few locals, but in a 1 week time, I may see 2 locals, and the rest will be from other places all over the country.
Okay. We are actually started to get few questions from the audience members, so thank you for sending them over. One of the question is regarding the video software platform you are using. And the concern is around the data protection and the HIPAA liability and all sorts of things, certainly. So can you tell me a little bit about the actual software? Is it the VA program we use?
Yes, it's the Teams program. It's all done through Teams, which is supposed to be secure. That's how we communicate, with the other doctors and nurses also.
Okay, okay. And when you do this visit, is this just the patient, or you also expect their caretaker at home to be part of the visit?
I definitely prefer for the caregiver to be there for sure. And I would say the vast majority of the time the caregiver is with the patient. Sometimes I'll get someone who's years out and maybe not complicated and they'll be there by themselves, but usually the caregiver's there.
So you mentioned like graft versus host disease, where you might want to prefer patients to come over for in-person exam. What are some of the other situations where you ask patients to come to for local care?
Sometimes if they're having frequent infections, we'll bring them here. Sometimes if the local provider is feeling uncomfortable, the patient's getting repeated infections, we will actually bring them here and sometimes even admit them here until the problem is cleared up.
Okay.
But yeah, usually it's infection or graft versus host disease.
Okay. Now, definitely, the relapse after transplant is probably the most challenging complications we all face. And um, can you walk us through kind of just general steps? Let's say you looked at the CBC from the local office and you realize that they're circulating blast, for example. Okay, and
Mhm.
what goes through your mind? How you coordinate with Dr. Savani and the local team as far as the salvage treatment goes? Nothing specific, but just the logistics of salvage therapy plus
Sure.
more definitive therapy like a donor lymphocyte infusion or second transplant in some cases.
Sure. So, of course, if I see blasts on the diff or a really high white count or really low platelets, the first thing we want is a bone marrow biopsy. So, we'll immediately contact the coordinator locally and ask them to get the bone marrow biopsy. We also want to recheck the donor percentage. So, we'll give them instructions on how to collect it on the bone marrow and the peripheral blood and send here so that we can run that and see if they're losing donor percentage. Um, of course, Dr. Savani's involved at that point, and will usually there'll be a phone call between the local provider and Dr. Savani where he recommends a course of treatment. We'll get the patient started. If it's someone that we think needs a donor lymphocyte infusion, we'll go ahead and start getting that on the radar too and ask the local team to submit any additional testing that we might need to make that happen. So we'll do frequent follow-up in the case of relapse, at least once a month, if not more often, to make sure we're on top of everything and ready to act, and get the donor going as soon as we need to.
And for actual DLI, patients comes to Nashville, correct? Okay.
Definitely.
And
Yes,
do they
we'll
have to stay here after the DLI, or they just can go back to the home immediately?
we keep them here. So if they have a mixed chimerism, then they'll stay for about a month, sometimes less if they're doing well. If they're 100% donor, usually we have them stay for about 2 weeks, but once they go home, we still follow them up once a week, every other week for a good while.
Okay. Okay. And one of the questions we have received is like how these long-term patients are getting discussed with the rest of the transplant group. Like how often other physicians get updates about these cases.
Sure. If we have patients having major complications, Dr. Savani or I will always bring them up in our weekly team meetings to get opinions of all the other attending physicians and get the team consensus. Also, Dr. Savani will call colleagues from all over the world to ask their opinion as well.
Okay. I think I we mainly talked about post allogenic transplant long term care so far, and we are increasingly relying on CAR T cell therapy for multiple other malignancies, ALL, multiple myeloma, lymphoma, and this patient also faces some of the long term immunosuppression, infectious complications, sometimes second malignancies. So, do you have any long-term post-CAR T care workflow within your system?
Not currently. Right now, this clinic is only for the allos. Um, but I know that they have recently started more of a long-term follow-up with the nurse practitioners that took care of that patient during their CAR T. So I know that they have a day 30 before they go home. They have a big follow-up. And then at day 100 now, their nurse practitioner will do a video visit as well. I do think that is a clinic that's going to be expanding.
Okay, okay. Uh, okay, well, I think we covered most of the questions from the audience member at this point, and oh, there is one more actually. Is there any follow-up after 5 years? So somebody is doing really well and no complications. Do you release them formally at any point, or you still keep seeing them?
I never release them. I even have a couple patients that are 28 years out post-transplant. As long as they're willing to keep seeing me, I keep seeing them at least once a year.
Okay, okay. And right, of course, many of our patients come from rural parts of the country. Have you ever had a challenge with getting an internet connection for these patients? Is there any resources through the VA to get the internet connected for these video calls?
Actually, yes, that's a common problem for us. I know the home VAs will provide a hotspot for the patients if they request it. That's something they give them for free. I've also had some patients that don't have internet at all, in which case they can go to their local VA and we can do the visit that way, where they'd go there and do the visit from a clinic room.
Okay,
But yeah,
okay.
we do have that issue sometimes.
Just for the audience member who are not familiar with the VA system, so that is a nationalized healthcare program through a Department of Veteran Administration. And this is a program set up through federal government in United States, where they have multiple hundreds of clinic location as well as inpatient facilities all over the United States, Puerto Rico and Hawaii and Alaska, to provide the care for patients who had prior served in the military, United States military. So there are of course large volume of patients, and they get cared. Most of them get cared in the community, but when they develop serious medical diagnosis such as leukemia or MDS and need stem cell transplantations, their local oncologist refer them to a relevant specialty transplant center within the VA network. And so right now, Nashville is one of them. Seattle is another transplant unit in United States. Occasionally, we run into a situation where, because of the patient preference or logistics, patients might need to get referred to a local community transplant center wherever they are living. And they may get transplanted locally, but I think Rachel and Dr. Savani still sees them once they are through the transplant. Is that correct statement, Rachel?
Typically, it just depends. If they get transplanted in the community and their center has a long-term facility, sometimes they'll be seen there. But yes, often we do inherit people transplanted in community that get their follow-up here.
One of the question came from the audience is about the transplant outcome data. Again, we are required by law to report our outcome to CABMTR. And we do report our survival outcome and GVHD outcome regularly to CABMTR. And this data is collected by Rachel and her notes with all the GVHD grading and the relapse and patients' vital status at the last assessment. And so that get captured by our data team and submitted through CABMTR forms in the database. So the system is very similar to what we have at other program in the city here. Okay, I think this will wrap up our webinar for this morning. Again, thank you so much, Rachel, and appreciate all you do for our patients and spreading the joy and providing access to the specialty care in remote part of the country. So thank you. Take care.
Thank you. You too. Thank you.